Dupuytren's disease. When to intervene. Characterized by a progressive retraction of the fingers of the hand. This pathology of genetic origin is benign and very frequent. Its management depends on the severity of the attack. Where does Dupuytren's disease come from? Although first described in 1831 by French surgeon Guillaume Dupuytren, the disease that bears his name was handed down to us by the Vikings. Even today, the prevalence of this hand pathology remains higher in Northern Europe. There are almost no cases on the African continent, says D. Charles Schlur, orthopedic surgeon at the French Institute of Hand Surgery in Paris. Dupuytren's disease is defined by fibrosis of the superficial palmar aponeurosis. The palmar aponeurosis is a very thin membrane that sits between the skin of the palm and the deeper elements of the tendons, arteries and nerves, says D. Schlur. Normally, this layer is thin like cigarette paper. With the disease, the aponeurosis thickens to reach several millimeters and, as a result, loses elasticity, continues the specialist. It will extend less and may even tend to retract, limiting the extension of the finger. This abnormal thickening, called fibrosis, is explained by the proliferation of myofibroblasts, cells involved in the production of collagen. How is the diagnosis made? This pathology is quite common. It affects between 5 and 10% of the general population, with however more or less marked form. The signs appear between the ages of 40 and 60. Very often, when the patient searches his family history, he discovers an ancestor who also suffered from many factors such as alcohol, tobacco, professional microtraumas, diabetes or epilepsy are often considered to be associated with Dupuytren's disease. But D. Schlur is categorical. The origin is systematically hereditary. However, it is impossible to implement any form of preventio. Indeed, no physiotherapy, splint, ointment or massage can prevent the progression of the pathology. In half of the cases, Dupuytren's disease affects both hands. But if this pathology is bilateral, it is not symmetrica. As for the diagnosis, in most cases, a clinical examination is enough, says D. Schlur. Ultrasound, sometimes prescribed, is useless. What are the symptoms of Dupuytren's disease? Dupuytren's disease is characterized by symptoms related to the retraction of the integuments, that is to say of the tissue. It progresses in flare-ups and can therefore, depending on its evolution, remain unsuspected for a few years, especially since it is generally painless, which makes it possible to distinguish it from joint diseases of the inflammatory type, such as osteoarthritis or arthritis. In 75% of cases, the attack begins at the level of the 4 and 5 fingers. The little finger and the ring finger, describes the surgeon. There is the appearance, at the base of the fingers, of or several small balls, called nodules, or sometimes of a longitudinal cord, or bridle, in the palm of the hand. This subcutaneous induration will, over time, cause an irreducible flexion of the first 2 phalanges of the fingers affected, never the third, which end up remaining blocked. This permanent flexion, measured in degrees, continues to increase as the disease worsens. In severe forms, the fingers are reminiscent of claws, says D. Schlur. Putting your hand in your pocket, putting on a glove or even giving a handshake can become extremely difficult gestures to accomplish. What are the types of surgery? Treatment should be considered when retraction prevents full finger extensio. A simple test makes it possible to decide. As long as you manage to put your hand flat on a table, no support is justified, develops the Sergio. On the other hand, if the test is positive, a surgical intervention must be proposed, within a reasonable time so as not to compromise the chances of finding a full extension. Over time, in fact, the tissue's hard. 2 options are possible, depending on whether or not one chooses to eradicate the disease. And it is of course to be discussed with the patient, according to his profile, his age, his physiology. The first solution involves a percutaneous needle aponeurotomy, PAA. This technique consists of cutting the flanges, responsible for the flexion of the fingers, using a very fine needle. It is a gesture that can be performed under local anesthesia, and repeated several times over time. The aponeurotomy does not treat the disease. The aponeurosis is always hard and thick. Hence a high recurrence rate of 90%, within a fairly rapid period, observes D. Schlur. The alternative is aponeurectomy, which aims to remove the disease. This approach involves opening the palm of the hand and fingers to remove diseased tissue. It is performed on an outpatient basis, under loco-regional anesthesia. Sometimes skin grafting is necessary because the finger has retracted so much that when extended there is a skin deficiency. With aponeurectomy, the recurrence rate is about 10. If the operation is accompanied by a transplant, it drops to 0. This surgery is delicate. Complications, such as nerve or tendon damage, can occur during the operatio. In 3% of cases, this can lead to alga dystrophy, in other words a chronic pain syndrome in the area of the HON. And surgery is just one saint. Rehabilitation with a physiotherapist is essential to hope to regain good mobility of the HON. The installation of a dynamic finger extension splint, orthosis, made to measure, can also be recommended during the first stages to maintain the maximum extension obtained thanks to the surgery. The healing time is 2 to 3 weeks, between treatments and dressings, and the recovery time varies between 2 and 3 months, says D. Schlur. Data which explains that aponeurectomy concerns less than 5% of people with Dupuytren's disease. What are the characteristic signs of Dupuytren's disease? Stage 1. A subcutaneous nodule appears at the base of the affected fingers, with a beginning of flexion, barely or not mark. Benchmark. At 0 degrees, the finger is fully extend. Stage 2. The nodule grows. A bridle or cord gradually forms on the palmar surface. Stage 3. Only the first and third phalanges of the fingers are affected. The fingers tend to close. Stage 4. At 180 degrees, the fingers can no longer extend. The palmar flange which has formed and thickened keeps the fingers retracted in the palm.